Good evening, everybody. Thanks so much for joining us for our vaccine and variants town hall. We have three phenomenal guests. I know there's so much information out there right now, so we really wanted to bring together three experts to really give you the most up-to-date information. So thank you so much for joining us today. Let me just give you a little bit of where we are at with COVID-19. This is probably all a refresher for many of you, but I'm just going to kind of quickly go through it so you have the most up-to-date information. As you may know, we've seen over 3.4 million cases of COVID-19 with unfortunately 47,000 deaths. We are starting to see things turn around over the last month. So right now, today, there were 6,000, almost 6,500 new cases, but just compare that with 43,000 cases a month ago. The positivity rate is down to 3.7% versus 12%. Hospitalizations are down 39%, and ICU admissions are down 33%. So those are all excellent trends, and we're very proud of the work that we're doing. And I just want to thank everybody for masking up, staying home, being socially distant, avoiding contact with friends, family. I know this is so hard. When we started this a year ago, I don't think any of us could have imagined that a year later we would still be in this situation. But really, it's because of everyone's diligence that we are continuing to see improvement. Our testing capacity continues to improve. We've administered over 46 million tests. Over 6.2 million vaccines have been administered. In San Francisco, about 158,000, and in San Mateo County, about 145,000. We have a pretty diverse breakdown of vaccines that have been administered by race, and I'll just give you a sense. It's 32% white, 16% Latino, 13% Asian, 3% African American, almost 0.5% of Pacific Islander, and 26% multiracial. In terms of vaccine goals, you may have read that we have the state has contracted with Blue Shield to help administer vaccines more efficiently, and the goal is to administer 3 million shots a week by March 1st. This would be a significant increase in the capacity for the state, which would be phenomenal if we could actually get to 3 million shots a week by March 1st. That would mean that hopefully in a few months we could hope to vaccinate just about every person in the state. Blue Shield is going to be responsible for creating an algorithm to better determine how to get the vaccines distributed and really how to get vaccines to the hardest reached populations across our state. Kaiser Permanente is also expected to sign a separate contract to run a vaccination program for its members. And we want to make sure that this information continues to be up to date. The legislatures continue to do continuous oversight over both vaccine delivery, PPE delivery, testing, everything that is really occurring at the state public health level. I did want to just take a quick aside around school reopenings. I know that's been a very dominant discussion. So for all of you who have kids in schools, the legislature is working feverishly with the administration to try to get our school reopening plan approved. We know that the data is pretty conclusive that schools that are open, we haven't seen significant spreading. We haven't seen a huge number of super spreader events as long as safety is taken, precautions are taken, social distancing is followed, masks are worn. So we really hope that as many schools have opened and remained open, they've given us a sort of a pathway on how we can safely reopen schools. That's why I introduced AB 10, which continues to be sort of the Assembly's bellwether on how we could best open schools up safely. We know that children have huge amounts of learning loss and that after a year of distance learning, we know that there's been devastating impacts on learning loss, mental health, a whole variety of factors. I see it every day, and my two children who are in public school, they've been doing distance learning now for about a year, and it's been very, very challenging. It gets harder by the day. So let me just go from there to introduce our three panelists. I'm going to introduce them one at a time. I'm so honored again to have Dr. Rutherford join us again. He's an adjunct professor of epidemiology and health administration at UC Berkeley's School of Public Health. He is a foremost expert in epidemiology and the control of infectious diseases. We don't talk about where he went for undergraduate, so I left that out. But let me just start off with Dr. Rutherford, who we really appreciate for just coming back on with us again a year later and just giving us an update as to where we are and to really talk about both vaccinations, but also about the variants that we are starting to learn more about. So,
Sure.
Dr. Rutherford, I think you have a presentation that you're going to open.
And an assembly member, Ting, always points out my Cal appointment, which I do about a half a day, one semester a year, and I'm really a professor at UCSF with major holdings inside your district. So but anyway, I'll let you make the Cal part.
Fair enough. We love UCSF.
Fair enough. Okay, so I thought I'd start off just by talking a little bit about the vaccines that we have available and what's coming online. I think, as everyone knows, we have 2 vaccines made by Pfizer and then a Moderna, a biotech company in Boston, in association with the National Institutes of Health, that use a technology that involves messenger RNA to get cells to produce the spike protein, the part of the coronavirus that sticks up off the surface. That is what attaches to cells, and antibodies in your immune system see that spike protein. They will attach to it, and your immune system will kill off the virus. So the whole name of the game is to produce antibodies to the spike protein. So that's one set of technologies. We know I think many of us may have gotten at least one of these doses. As you know, they have very complicated storage parameters. The Pfizer vaccine, for instance, has to be stored at -70 degrees. They have limited times they can be defrosted. My favorite story of the whole epidemic, well, I have lots of favorite stories, is when a shipment of vaccine was being brought to Southern Oregon, and there was a big snowstorm coming over the pass, and all the cars got stopped, including the one with the vaccine in it, which was already defrosted to be given to people, and it was going to just go bad in the delivery truck. And they went up and down the line of stopped cars and vaccinated everybody who wanted to be vaccinated. I thought that was great. We have 3 vaccines that are coming online. The Johnson & Johnson vaccine is going to be heard. Its emergency use authorization case will be heard by the FDA on the 26th of February next week. This has a virtue of being a single dose vaccine. It uses a technology called adenovirus, where there's a different virus that we put the little gene in that codes for the spike protein. That gets it into the cells. The cells then produce the spike protein. The immune system sees it, and they're now sensitized to it. Novavax is a somewhat different technology that uses, and instead of tricking the cells into producing the spike protein, we just give the spike protein. The antibodies see it. The immune system sees it and creates antibodies to it. That's also a 2-dose series. The Johnson & Johnson, as I said, is 1 dose. These are both pretty stable in refrigerators. And then the last one is an Astrazeneca and University of Oxford combination. That this is also an adenovirus vaccine, although it uses a chimpanzee adenovirus. There's some nuance there that I can talk about. This is also stable in the refrigerator. And this is, we expect these trials to be done here pretty quickly. So those are the 3 that are in the pipeline. Now, you will have heard a lot about variants, and the way to think about this is this is all about the spike protein. This is what the spike protein looks like in 3 dimensions. But think of it, like in the good old days when we go to restaurants and there'd be, with your kids, and there'd be a guy there who'd be making balloon animals. So think of taking a really long balloon, bending it in 3 parts, so it's like 3 up and down segments, and then twisting it all up. That's what this is. This is a trimer. It's got 3 proteins all tied together, right? And it creates a 3-dimensional structure that presents a little piece that can actually stick to a cell at a specific binding receptor. Now, our antibodies attach to various parts of this, and but as this thing mutates, each of these individual little pieces are amino acids and they can change. You can get small configurational changes in the protein shape so that the antibodies can't see the same place. They can't find the right landing pad. So that's what these, when we talk about variants, that's what we're worried about, is whether the configuration is changed in a way that we can't exactly see what's happening. Over here, these are data from South Africa. And this is the yellow is this new variant, the S501Y variant. And you can see how it's become the predominant strain here later in the year. Okay, so these are the ones we worry about. Okay, so the first one, which nobody talks about, is these are all, so the way you read these are specific amino acids, and I put the names over here. And this is the where they are in this chain of proteins, chain of amino acids that make up the spike protein. There's something like 1,173. I can't remember the exact number. It's something like that. So you say what position it's in, and then what changed in it. Okay. So the first one was an aspartic acid to a glycine a mutation. And that happened in early 2020. The Chinese strain stopped circulating, and this strain replaced it. So we had one big change already. Now, more recently, we've learned about three different things. One is an asparagine to tyrosine mutation, and that's present in several lineages, including the British lineage, the South African lineage, and the Brazilian lineage. This helps the virus bind more tightly to human cells. It becomes stickier. This little kind of appendage from the spike protein that hits the receptor sticks better. Okay, so that means it's more infectious. Another is a glutamic acid to lysine modification. This appears in several lineages. And this is particularly problematic because it seems to create these folding changes that mask the landing sites for antibodies. So this is in the South African strain predominantly, but also in the Brazilian strain. And then more recently, we found this lysine to arginine mutation, which has become very common in California, and I'll speak more about that later. We don't know whether it really has any biological import in terms of severity of disease, transmissibility, or avoidance of antibodies. We don't think so, but the studies are ongoing. So the variants that we worry about, there are three big ones. There's this is the UK variant, which has all these different names. This is really common in Britain now. It's more infectious, and it may actually cause slightly more severe disease. This is rapidly becoming the predominant variant in the United States. There are large outbreaks of this involving this variant in Southern California and San Diego, but it's really starting to be found all over the country. This B1.351 is the South African variant. This has this E484K mutation in it, as well as this more transmissible one, and it reduces the effectiveness of some vaccines. And in fact, it was studied directly with the Astrazeneca vaccine, and it reduced its efficacy to 22%. And the South Africans dropped that as a solution. And then finally, the Brazilian strain, and this has mutations similar to the South African strain. And then this other one from California, which is typically called Cal.20C for God knows what reason. But that's not something we're seeing much of yet. So how well does the current vaccines, the mRNA ones we have right now, work against the variants? The UK variant appears to be fully susceptible. The South African and Brazilian variants appear to be less susceptible, but not totally unsusceptible. That is, they have some activity. And what they may protect against is they may not be very good at stopping transmission, but they seem to be protective against severe disease, which is what we really want. And there are no data yet on this California variant that I mentioned. So these are data from the South African National Blood Service, where they love smiley faces for some reason. This is not my doings. So the J&J vaccine, which again is a single dose, if you look at endpoints of hospitalization or severe disease, it has 85% efficacy. The Pfizer vaccine, this is against the South African variant, The Pfizer vaccine works well in the laboratory. The Moderna one, okay in the laboratory. This is Russian, don't worry about that. You're not going to be able to get that. The AstraZeneca one does not work well in the laboratory and did not protect against mild or moderate disease. It may protect against severe disease, but those studies are ongoing. Novavax did okay, not great for mild and moderate disease. And another Chinese vaccine seems to work well in the laboratory as well. And these are CDC's projections. This is probably the more likely scenario. This is with the current variants that we have, and we would expect those to drop, right? The numbers of cases to drop as we're seeing, but the number of cases that are caused by the British variant, the B.1.1.7 variant, to increase, and in the United States to replace the current variants that we're seeing by, say, April sometime. And here we can see what the prevalence is in California. Looking out here, these are data from Cedars-Sinai in Los Angeles. This is the British variant. You can see how it's sort of come out of nowhere. And this is this Cal 20C variant. Again, the one we're not quite sure of what's going on with that one, whether it's more pathogenic or not. This is overall in all of California. And this is in Southern California, where the British strain is somewhat less pronounced, although it has been associated with outbreaks in San Diego. So that's the news around the nation for variants and vaccines. And I'd be happy to answer questions when the time comes.
Great. We're going to get to our other panelists, and then we're going to go and get to questions. Next, we have Dr. Baba, who's the Deputy Director of Health at the San Francisco Department of Public Health. She's been there since 2009, although this year feels like probably like a dog year or like an animal year, so it doesn't quite count. I'm sure it feels a lot tougher than all of the years in the past. And at SFDPH, she helps oversee a team of both primary safety net providers for San Francisco, as well as the overall responsibility for ensuring public health functions are met. So with that, we're going to go to Dr. Baba.
Thank you so much, Assemblymember Ting. Just to follow up on Dr. Rutherford's presentation, I'm going to talk a little bit about the vaccine strategy here in San Francisco. But I think one of the key points here is that, as far as we know, vaccine is the best tool we have for prevention, along with our mitigation strategies of masking, social distancing. So really want to continue to emphasize both of those in our fight against the pandemic. And then in terms of our own vaccine efforts, next slide, please. We are really guided by three major principles: equity, speed, and partnerships. We know that COVID has unfortunately had a disproportionate impact in certain communities. And so want to ensure that we have equitable vaccine allocation and administration. But in terms of how to do that, we have to also balance the fact that we need to adhere to state and federal guidelines that have been done by our scientific communities, and that we're using our supply in alignment with those priorities. We want to prioritize rapid access to communities, and obviously want to be transparent in all of this work. I will say that given where we are with vaccine, it's been unprecedented in terms of our collaboration with all of our partners here. And in order to get vaccine out, we do have to have that unprecedented collaboration with all of the major healthcare systems, as well as with the smaller providers. Next slide, please. So in terms of the phases, again, as I stated, this is really driven by the federal and state guidelines. And currently there was just a change, last week, which I'll talk about. But in December, vaccine opened up for our healthcare workers as well as our long-term care residents. And most of December was spent vaccinating that group, as well as into early January. San Francisco moved into phase 1B in terms of vaccinating individuals 65 years and older in early January. And right now we are vaccinating healthcare workers as well as those that are 65 and older. We are going to move into the next part of 1B, which is certain sectors, including education and childcare, emergency services, and food and agriculture, starting next Wednesday. And then I think hopefully, as most of you have heard, the next phase will be individuals ages 16 to 64 who are deemed to be at very high risk for morbidity and mortality from COVID. I will say that all of these phases people can be eligible at any specific time, but obviously they are dependent on the amount of vaccine supply. And just in phase 1A plus the over 65-year-olds, we have over 200,000 San Franciscans that qualify for those phases, and yet we have not received vaccine enough to vaccinate that group. So that just tells you kind of where the critical stuck points are in terms of getting vaccine out. We are hopeful, as was discussed, that more vaccine will come on the market, as well as production will increase, so that supply will not be an issue, hopefully in the next couple months. Next slide, please. And then in terms of how vaccine flows into San Francisco, this is just to illustrate the fact that there are multiple different ways that vaccine is flowing into the city. San Francisco, the Department of Public Health receives about 1/3 of the allocation. And again, this is illustrating why that is. So the federal government directly allocates to federal entities like the Veterans Administration. It also early on had a partnership and continues to have a partnership with the pharmacies. And the initial partnership with CVS and Walgreens was focused on our nursing homes and our long-term care facilities to vaccinate those very vulnerable residents as well as staff. Now, actually, as of this week, it's moving more into the commercial aspect where the federal government is allocating to CVS and Walgreens throughout the state where people can directly access vaccine if they qualify. And there are, I believe, 2 places within San Francisco that will start that this week. And the goal is, at the federal level at least, to increase those allocations as supply increases. And then finally, the third way that vaccine flows into San Francisco is through the state allocation, and the state allocates in 2 different ways. It allocates into what is called multi-county entity programs. The easy way to think of this is large healthcare systems. So it directly allocates to large healthcare systems, and in San Francisco, that includes Kaiser, the UC San Francisco system, Dignity, and Sutter CPMC. So they receive direct allocations from the state, and then the state also directly allocates to the local health department. And like I said, that's about 1/3 of the allocations coming into San Francisco. Our job then is to allocate to healthcare systems that are not large healthcare systems, that might be more San Francisco based. So for example, in San Francisco, we allocate to the health network, or San Francisco Health Network, which includes San Francisco General Hospital, but also to entities like Chinese Hospital, our consortium clinics, and other entities that are requesting vaccine. Next slide, please. So that's how vaccine flows into the city, but I will say that, as I initially stated, that there needs to be really high levels of collaboration to get vaccine out into the city. So all of these entities, all of us are working together on a kind of comprehensive strategy of how to approach vaccine. And it's really landed into 3 buckets here. One is our high volume vaccination sites, and there are 3 of these within San Francisco. There is one in City College, which is in partnership with UCSF. There is one at Moscone, which is in partnership with Kaiser, and then a third one that just launched today in the produce market in the Bayview, which is in partnership with Sutter. And we are partnering with these healthcare systems so that they can provide vaccine, and that's independent if you're a member of their network or not. All you have to do is be eligible for the vaccine, and you can go to these high volume vaccine sites. The second way that we're distributing vaccine is through our community access sites. And this is for places that need a higher touch. So obviously our community clinics are a huge partner in this, and our consortium clinics as well as our DPH clinics are receiving vaccines to vaccinate populations. And most of these populations have been disproportionately impacted by COVID. But we will also have vaccine access sites or hubs where communities can go to get vaccinated. And finally, we will also have a mobile vaccination strategy specifically aimed at people that cannot get to vaccine sites. And then finally, as I mentioned, the pharmacy partnerships are going to be essential in this, and that a lot of people actually get their vaccines at pharmacies. So really want to ensure that that information is provided to the public as well. Next slide, please. So as I mentioned, these are just some of the entities where that are participating in each of these sites. The high volume sites again, are with our healthcare systems and healthcare partners, really meant to reach a large number of people in a very efficient, fast manner. Our healthcare systems also are providing vaccines to their members at each of their sites. That's the San Francisco Health Network, which is DPH affiliated and run, is providing vaccines to their patients. Our community clinics include not only the San Francisco Health Network clinics, but also our consortium clinics like Mission Neighborhood Health Center and NIMS, Health Rights 360, as well as partnerships like Chinese Hospital and One Medical for specific populations. And then we are working on neighborhood sites. We have a neighborhood site in Mission, we have a neighborhood site in Bayview and other sites in development, as well as a mobile vaccine strategy. And with all of these sites combined, we will be able to do well over 10,000 vaccines a day. The limiting factor right now is vaccination. And then, I'm sorry, I forgot the pharmacy partnerships, which include Safeway, Walgreens, and CVS. So I will stop there. We do have a lot of information on these websites, including data about how we're doing in terms of vaccination.
Okay. Next, we are going to have Ms. Srinivasan, who is the Deputy Chief of San Mateo County Health. She's been there for 13 years, and under her leadership, San Mateo County Health has reduced the number of uninsured residents, piloted innovative approaches to healthcare delivery, reduced the burden of persistent health disparities, and partnered with stakeholders to create more equitable communities. So let's go to Ms. Srinivasan now from San Mateo County Public Health. Thank you.
Evening, is this sound okay?
It sounds great.
Okay, nice to be with all of you. Thank you, Assemblymember Ting and Dr. Rutherford and Dr. Baba. I think Navina captured a lot of the basic approach that we Bay Area local health departments are following, and I was able to hear from many of your questions this evening, so I want to make sure that there's time for those. Let me figure out how to advance my slide. So as Dr. Baba talked about, we in San Mateo County Public Health are guided by these principles of safety, which Dr. Rutherford gave you a good thumbnail of, transparency, and I heard in a lot of the questions that were forwarded to me over the weekend, how challenging it is to understand what's going on in this landscape. Why is it so difficult to know if it is your turn, if you are an older adult, if you are a healthcare worker, how to get vaccinated? And we're striving every day to make that as clear as possible, understanding that we have a pretty diversified healthcare system as a whole. So local public health's job is to try to make it as navigatable as possible. And then as Dr. Baba talked about, this equity responsibility is very deep. The pandemic has not been born equitably in who it's affected and how protected we are. So this is an important consideration in the way the vaccine rollout is occurring in San Mateo County. You heard from Dr. Baba about who's eligible, both as deemed by the state as well as in our local jurisdictions. And we too in San Mateo County, you know, Daly City southward, for those of you who are joining from the northern part of San Mateo County, are vaccinating healthcare workers and older adults. On Monday, February 22nd, those 4 essential worker groups that the state recently expanded will be eligible to be vaccinated. And we understand the state's eligibility for those residents age 16 through 64 who have an underlying medical condition will be March 15th. We will be considering what that eligibility date will be for residents of San Mateo County. As with everything related to the vaccine at this phase, it's dependent on supply, and supply is the constraint of the pace at which the vaccine is being made available in San Mateo County, whether by public health or by our local healthcare partners. We have tried, our website traffic has gone to about 300,000 residents, and that's a little more than we had pre-pandemic, to make the information about how to be vaccinated as clear as possible, and the link is here. We have vaccinations occurring at more than 24 locations every day across San Mateo County. And the larger healthcare systems in particular, the 2 Kaiser campuses, the Sutter mass vaccination site at the San Mateo County Event Center are major resources. And we also have arranged mass vaccination efforts this week at SFO. And there actually were appointments available at around 4:30 for those older than 65 who are San Mateo County residents for Friday, if you haven't found a pathway. And then we also have a survey form to be notified by County Health if you're a San Mateo County resident and you're seeking a vaccination in our county. There is a new development that Assemblyman Ting framed up for us about the Blue Shield of California role. And we in San Mateo County, as well as most Bay Area health departments, will be onboarded to a new platform for being notified called My Turn on March 15th. So between now and then, we recommend that any residents sign up for both our local form as well as the state My Turn platform. So you're getting as much information as available from both the state pipeline as well as your local health department. We have a fair amount of information on our website in terms of how we're doing as a community. As of this morning, we had around 110,000 residents vaccinated. We've reached just about half of our 65 plus residents. We know that many have still not been reached and are looking for that pathway. And, you know, we're just striving to make sure that everyone knows how to get connected and that we continue to also reinforce the safety and efficacy of the vaccine for all of us to be as protected as possible. Speed is really important in both reaching everyone who is vulnerable and for all of you who want to be protected, and also from continuing to make sure that vaccine supply comes to our Bay Area communities as we roll out across the state and across the country. It's been really, frankly, educational and inspiring to see how quickly we have been able to mobilize, even understanding the frustration for those who are still looking for the way to have that reach you. And we also have been learning a lot that for some residents, we need to have predictable supply so that the pathway includes the supports, whether that's transportation or increased support at the site. So not all of us are experiencing these challenges in the same way. I'm going to make sure there's plenty of time for your questions. So just wanted to give that brief overview, and I'm looking forward to our conversation.
So we have a question on, we have a number of questions on variants. So Catherine from the Sunset for Dr. Rutherford. I'm just going to go through these questions and happy to repeat them if you know, there are too many of them at the same time. What is the difference between a variant and a strain? Are some variants / strains more likely to have side effects? Is there anything that can be done to help survivors with long-lasting side effects to their breathing or senses of smell and taste?
Yeah, okay. So strains and variants are just the same word for different words for the same thing. So the difference is they're spelled differently. But it's not really it's not a big distinction that's being made. At some point, we start talking about subtypes where they're really stable types in a population. But right now, the strain differences we're talking about are these ones that have collected a number of mutations and seem to have kind of taken on a life of their own, like the UK strain or the South African strain or the Brazilian strain. Some of these are going to cause more severe symptoms, possibly. Some may cause less severe disease. Some may be more transmissible. Some may be less transmissible. All those things are being figured out, are being worked on as we speak. In terms of long-term sequelae, we really don't understand that very well yet. We know that they're common and people are fatigued and have, I mean, the scientific term is brain fog. They have sort of problems with mentation and feel sort of thick-headed. And it appears to clear very gradually in some people. We don't really know whether this is a ongoing long-term problem, permanent problem or not. I can tell you that the loss of taste and smell it does gradually come back in most cases. But I really can't put numbers on it right now. They're tough questions, and then we're just trying to unravel them now.
Great. No, thanks so much. So Ting from NOPA said, which new variants of COVID-19 have been found in the Bay Area? And you kind of talked about them a little bit already.
Yeah, so so we were surprised that two of the sorry, I think it was South Africa. Yeah, the South African strains were there were two people at Stanford who tested. The lab was Stanford. I'm a little unclear. One person came from Santa Clara and the other from Alameda, both of whom tested positive for the South African strain. So that's and there may be a second case of some person who lived in the same household in Santa Clara County. Those people were properly isolated and quarantined. And so that probably is contained. I think the British strain is something that we're going to start seeing lots more of. As I said, there's quite a bit in Southern California, but there's more up here as well. We've yet to see the Brazilian strain. That's only occurred, as far as I know, in Minnesota so far in the US.
And then you talked about the vaccines and their effectiveness with these different strains.
Yeah.
So do people need to be concerned? Because we've been hearing so much about Pfizer and Moderna, and
Right.
they got, as they're getting the Pfizer or Moderna vaccine, are they going to have to possibly go back and get another vaccine maybe a few months later?
To be determined. Right now, we know that the British variant, this 1117 variant that we were talking about, is which will likely become the dominant strain in the United States, is susceptible to the vaccine. So that's good news. If that's the way it stays, then we don't need to go back and get vaccines. If it starts to be replaced by the South African or the Brazilian strain or something new, or if this California strain turns out to be worse than we think it is, it's quite possible that you would get like an annual booster or come back in a couple of years and get a new version of the mRNA vaccine, which has these newer variants in it. I can tell you that both Pfizer and Moderna are in trials right now trying to produce new vaccines to meet these challenges.
No, thank you so much. And then Mary from Golden Gate Heights, and this is just to everybody, so feel free to chime in, is what is the extent of or plans for gene sequencing COVID-19 cases in California and the Bay Area? Are there updated contact tracing policies for identified cases of these new and more contagious variants?
Ravina, that's you, or you want me to answer that?
Well, Ms. Srinivasan was the first one to go. You want to go first? I saw you very excited. Go ahead.
Well, I would just say that more and more sequencing is occurring. We know that it's not sufficient to have perfect surveillance by any stretch of the imagination. Folks have probably been reading media about this phenomenon. Local public health departments are providing additional specimens to be sequenced to help us learn more and more. From a contact tracing or public health mitigation standpoint, Dr. Baba can certainly chime in, but the core mitigation measures are the same, that to seek testing and to stay isolated or quarantined as the circumstances demand. We do try to go as deeply as we can to find the index case, so that if there was a travel related pattern or some other pattern, we can keep learning, what else should we know? But these protective measures, which are tiring and we've been talking about for many, many months, are even more necessary given the transmissibility of these strains.
Great, thanks so much. Anybody else want to jump in on that, or that was?
I mean, I've talked a little bit about ring vaccination, which is a strategy that's been employed for other vaccine preventable diseases, where you preferentially not vaccinate the immediate contacts, but the next ring out around those immediate contacts. That's kind of hard to do with a 2-dose vaccine, but when we get the J&J vaccine, which is the Johnson & Johnson, which is a single dose, then I think that becomes much more of a practical kind of consideration to at least try out. And that would be sort of an extra layer that you could layer on top of, as we heard, the traditional things of quarantine and isolation and trying to test and get to the ends of the transmission trees.
Great. I don't know if you want to add anything, Dr. Baba, or I can just go to the next question.
I think it was well covered. Yeah, go ahead.
Yeah. Trolls from Pacific Heights. I've read that the South African variant is already resistant to the Astrazeneca vaccine. It's not just important to vaccinate people in the US, since this is a global pandemic. how can we keep the coronavirus from mutating? Will it be possible to vaccinate people fast enough against all future strains that may develop here and in other countries? It's a great question.
For me?
For anybody, for any of you. But you can jump in, Dr. Rutherford.
Okay, well, I don't want to hog all the time, all right? But, you know,
No,
this is kind of
jump
coming
in.
into my strike zone here, so I'll
We
take
have
a whack at this. The Astrazeneca vaccine was, and the paper just came out like 2 days ago. The Astrazeneca vaccine was tried in South Africa in younger people. I mean, and the older I get, the younger, the sort of the older what younger means to me gets. So it's like, they were like 20 to 45 or something like that. And it had endpoints not of clinical disease, but of PCRs, of the viral swab. So they were just looking for infection, not for clinical disease. And in that population, with that endpoint, it had a vaccine efficacy of 22%, meaning that it reduced your risk of infection, but only by 22%. So that's not that great when we have all these other possibilities. So they have stopped importing that. They've given their supply to the African Union to use in the rest of the continent. Now, but understand that there was a very different standard being used, and it was used in a younger population. You know, if they were using it in people 60, if they looked at people 65 and older and looked for clinical disease endpoints, they may have found something very different. So be that as it may, this will unravel over time. Right now, we think that as I said, we think that the currently used vaccines work well against the South African variants. One works better than the other, and the Johnson & Johnson, at least based on some kind of laboratory data, seems to work pretty well as well. Not as well as it does against the current strains, but pretty well. So I think we get protection from those, you know, but we have to stop the virus from mutating. So the way we stop the virus from mutating is not let it get transmitted, right? It's when it gets transmitted, that's when it replicates, and that's when it mutates. Okay, so it's, you know, so how do we stop it from getting transmitted? We wear masks, we socially distance, we avoid crowded spaces, especially indoors, and we get vaccinated when our time comes, when our number comes up. So, you know, the way this is a race, we want to get the population vaccinated before these things, you know, and these will continue to mutate. That's what viruses do. This is luckily a large virus that has has an enzyme in it that actually tries to keep the RNA sequence. It sort of seeks out and chops out the spontaneous mutations as they occur, but still viruses mutate, and we're going to continue to see mutations. Some may favor the virus. Some may favor the evolution of the virus to a more commensal kind of organism where it can live with humans, like the alpha coronaviruses do that we get colds from every summer. Or it may make it worse. It may give the virus an extra layer of fitness that it's harder to be, you know, especially when you start exerting pressure from vaccines and naturally acquired infection. We'll just have to see. But if there's no more transmission, there's no more replication, there's no more mutation. So that's the name of the game.
Great. Well, let's talk about how, you know, who's eligible. I know you talked about it in your presentations, both Ms. Srinivasan and Dr. Baba. You know, Deb from the Marina again wants to know, how do I know when I'm eligible to get the vaccine?
Yeah, and I can talk a little bit about that. So one of the important things is it is slightly different from county to county. So that might be one of the considerations.
You should just talk about it from San Francisco and Dr.
Yeah.
And then Ms. Srinivasan can talk about from San Mateo. So we can just talk about it from our counties.
Yes, so in San Francisco, it is right now it's over 65, and if you're a healthcare worker, or if you've lived in a long-term care facility, And then in terms of, upcoming phases, we do have on our website a form that you can fill out, identifying either age-based or sector-based. And when you become eligible, we will notify you. But as was also mentioned, the state is rolling out with a similar eligibility criteria that you can also sign up for if you wanted to have the double coverage and ensure that you know exactly when your eligibility may come up. But again, even at the state level, you want to make sure that your county is providing that vaccine at that specific time, just given the vaccine supply limitations.
Great. And how about San Mateo?
Same answer, just different website for the form to fill out.
Great. And I guess, so if I know my eligibility is not now, but coming up, what should I be doing? Should I just sign up and you'll let me know when it's my turn to sign up, get an appointment?
Yes, exactly. It will let you know that you're eligible because of what you've provided as information. And then all of these websites, including our own, has information about where you can get vaccinated.
Great. Claudia from Visitation Valley asked, how soon do you anticipate teachers will be vaccinated to be able to reopen up schools?
So for San Francisco, there are a number of schools that are open and continue to stay open with all the mitigation measures in place. For public school systems, we're working with the school district very closely in terms of understanding what their reopening plans will be and how we can support them. And the plan is to, as they're going to have to open up in phases, and so we want to support vaccinating in phases as well.
Got it. So do you have a sense of, the mayor talked about teachers being able to start getting vaccinated February 24th. Are we going to be seeing teachers getting vaccinated on those days then?
Yeah, I mean, it will open up to that entire sector. And then specifically for San Francisco Unified, we're working very closely to identify the teachers that they say are prioritized so that like I said, that first wave of teachers can get vaccinated and go back into the school system.
Great. And Ms. Srinivasan, how about San Mateo?
Similar landscape, and several schools are open, and both public and private, and some are completing plans to become open safely. We're partnering very closely with our County Office of Education, County Superintendent, who worked with the districts to have a survey that gives us information on health insurance and healthcare provider, so that we can coordinate the pathways that will be available to vaccinate teachers. A high proportion are insured by Kaiser. Many are connected to Sutter, and then the county is working very closely with our school partners on the pathways for those that don't have a Kaiser or Sutter connection.
Got it. I just really urge you, because oftentimes I represent North County, and we always feel like North County gets forgotten. So I know that there's a vaccination site in San Mateo, but we really need your help in getting one up in North County.
Yeah, we're at SFO this week, and continue to look for great locations, and working with North County partners such as Northeast Medical Services and others. So totally hear you, Assemblyman Ting.
Appreciate it. So Claudia from Ingleside Heights asked, I work for a university. Are university educators and employees two separate groups of people? And when will they get the vaccine?
I believe the sector guidance for education includes universities, and oh no, Dr. Rutherford is saying no, and he's a professor, so he would know better than me.
I claimed I was a public school teacher. That didn't work too well, but yeah.
I hope it doesn't, because universities have all decided they're not going to go back until the fall. So
hey, we're back.
We don't, I'm sorry?
I said we're back more or less, but we have to teach at the bedside, so it's sort of a bit of a different case at UCSF.
Well, you work for a medical university, so you've never stopped, right? But I think for most other educators, they've decided to
that's
Zoom.
I'm just creating an exception. That's
right.
all.
But
I got something from, believe me, I got something from Cal's University Health Service wanting to know if I wanted to be vaccinated, but that was because I was over 65. So I think maybe they're trying to vaccinate within the strata. I'm sorry, I don't mean to correct you.
No.
So I can just double check on the state's site, but I believe that the state's definition of the education sector includes higher education. Of course, there will be prioritization and, as vaccine supply allows, and then employers such as universities likely play a role in prioritizing among their workforce. But I'll double check as we're chatting.
Yeah,
I know
that's my
we're having
understanding
I think
too,
we're
is,
And we're basically, we're having that debate at the state level, because I'll just say as a legislator, I know my opinion doesn't really matter that much, but it doesn't make any sense to me. So we are.
but it is, Assemblymember Ting, to your point, it is based on occupational exposure. So if you're not currently in schools and don't have plan to be in, likely, will be lower down on the list.
Perfect. Jillian from Ingleside. I'm a 48-year-old multi-organ transplant recipient. The CDC listed my condition among the highest risk for the worst COVID-19 health outcomes. Why has the governor eliminated Group 1C priority access to vaccinations?
So I'm not, you actually do qualify in the next grouping, which would be March 15th, the 16 to 64 with, that are high risk for morbidity and mortality. Solid organ transplants is on that. So and that just speaks to the fact that there are changes happening. And so people, we try to get that information out, but if you feel like, you're maybe not being adequately represented, to continue to check back, because the state is making changes to how they're vaccinating and what their approach is.
Perfect. So you would just tell Jillian to sign up on your website.
Yes.
Yvonne from Daly City, in-home support services patients should be vaccinated along with their provider, as the patient is the one with the chronic condition. This isn't fair. Is anything being done about this? So it says in-home support services patients, not necessarily the provider.
Yeah, so right now, in-home support services members, beneficiaries who are 65 plus are eligible, and we did encourage in various efforts we've done over the past several weeks, please come with your IHSS provider so we both could be vaccinated together. For in-home supportive services beneficiaries who are below the age of 65, if they have an underlying medical condition, as we were just talking about with the last question, they would become eligible March 15th. For others who are younger, they're not yet eligible, and will continue to follow the state guidance about that group.
Got it. So this is a similar question, so I assume it's still the same answer, which is Philip from Laurel Heights and Michael from the Sunset. They ask, how soon will the vaccine be available to those formerly in the 1C group and then everyone else, including those of us who aren't in a high risk or essential category? So it sounds like the 1C group's available March 15th. Is that?
I don't believe they're called 1C anymore. Like, they're part of the next phase. Yes, March 15th at the state level, and then counties, pending the role of Blue Shield, would be adopting the state guidelines as supply allows.
And then everybody else, it sounds like we don't have another date for a category after that. Is that correct?
You may know more than we do, Assemblymember Ting, but as far as we know at the local level, the next that would be considered, we've heard from the state, is an age-based framework, that there could be some tiering based on age below 65. And then there are expectations that we will get to the general public by the summer.
Yeah, I may know more, but I don't know that it's any clearer to me, unfortunately. So this is actually very helpful, and frankly, my feeling is, which I think is the right way to do it. It feels like the county public health officers know the soonest, and so that to me is probably the most appropriate course of action. So I always kind of recommend that people look at both your county websites, because that, in my opinion, probably is the most up-to-date information. So Donna from South San Francisco asks, should entire households get vaccinated at the same time if there was a healthcare worker or elderly person living under the same roof?
Donna, so if you have two household members who qualify and can come together and you're in a household in terms of the public health definitions of household, that often works really well. We do know of other family situations in which people space out getting vaccinated because there could be some side effects and, juggling responsibilities and the like. And then in many households, not everyone is eligible at the same time because we're in different sectors with different exposure and different ages. But if it can work for the healthcare worker and an older adult, often that's a great combination.
Got it. Shirley from the Richmond asks, I understand that people with health conditions that put them at higher risk of COVID-19 are going to be eligible to be vaccinated soon. I have an autoimmune disorder, plus I'm on a drug that causes me to have a lower immune system. However, my rheumatologist doesn't know anything about how to prove my condition to demonstrate that I'm eligible to be vaccinated. What should I do?
So I think the next eligibility for March 15th is still being worked on at the state level. We want to make this low barrier. There needs to be a little bit of trust that the public, that we have with the public and the public has with us in terms of saying, self-identifying that you fall into this category. So I don't think there's going to be a lot of emphasis on bringing certain medical information to sites. Right now, even for healthcare workers, it's just attesting that you're a healthcare worker, right? We're not checking in any way, shape, or form. And I assume that's going to be very similar moving forward, that the people who meet these criteria will self-identify and will qualify. But I think that's still being worked out kind of at the state level as well.
Got it.
I would, however, add, if I may,
Please.
Vaccinating people who are on complicated anti-inflammatory drugs is complicated. And you really need to work with your rheumatologist. It's not so much that it increases your risk of side effects, it increases your risk of the vaccine not working. So there's some real exquisite timing that has to go on, and it's different for different conditions and different for different drugs. It's complex, and this is something to be working with your rheumatologist about.
Okay, that makes a lot of sense. So appreciate that advice. Chris from Oakland, if I work in San Mateo or San Francisco counties, but live in another county, where may I be vaccinated?
So with a healthcare worker, we did honor folks who either live or work in San Mateo County, and that is the approach we would want to follow for the next groups of essential workers to try to remove barriers. And most of our Bay Area counterparts have taken the same approach.
Got it. And you don't feel that's disadvantaged either county, or created, a situation where people are coming to a particular county?
We have a very fluid ecosystem of where we live and work and get supported. So we want to make it as easy as possible.
So one question for both of you, because there's been discussion, you both mentioned kind of supply issues. Los Angeles already had to shut down one of their vaccination sites. Do you believe that supply is going to keep up with the pace? I mean, just looking at the charts that you have, the distribution channels are opening. You're basically making it much easier to get vaccinated, which is what we all want. Do you anticipate potentially having to do a pause or having to slow down because of the lack of supply?
We're definitely limited by the flow of supply, and we could be getting to more people more quickly if there were more supply to our county. And that means to Kaiser, to Sutter, to the county that's allocating and distributing to our smaller healthcare providers that are locally based.
Yeah, and we actually, our Moscone site and our City College site had to shut down because of lack of supply as well. So supply is the biggest issue right now in the ability to get vaccine out. And I will just say for that former question, there are a couple assets regionally. So there's the one that's opening at the Oakland Coliseum, as well as the one in San Francisco, the Moscone Center. I believe maybe even Santa Clara has some sites that are open regionally to people. And so you don't have to go to your county-based place of work or living. You can go to any of these sites that are regional in nature.
And just with regard to the vaccine supply, we could get a bump at the end of next week, early the following week, because of the Johnson & Johnson vaccine coming online. They apparently have 100 million doses ready to go. So that might make a lot of these problems go away.
Perfect. So you had mentioned, so just to kind of pick up on that, right? You'd had that great slide, Dr. Rutherford, of all the different vaccines coming online. You mentioned Johnson & Johnson. How much more supply do you think is really coming in the next month or 2 or 3?
Hundreds of millions of doses. I mean, President Biden has invoked the Defense Production Act to compel the manufacturers to increase their production lines. We have the J&J vaccine coming online, which remembers a single dose vaccine, so you don't need 2 doses for everybody. And the J&J vaccine is, I mean, man, I take that in a heartbeat. I get that in a heartbeat. It's, first of all, I get protected a lot faster.
Yeah.
And it's, it'll be great when we get it.
Mhm.
So-
And you said you get protected a lot faster, meaning because it's only 1 shot versus 2 shots.
Correct. Right. Correct. It's just, you don't have to wait for the second shot.
Great. We had a number of questions on vaccine effectiveness. We had Maria from Daly City asked, are actively infected COVID-19 patients able to get immunized? And how many more variants can there be of the coronavirus, and will we need to get vaccinated against each one or vaccinated multiple times? So I know you sort of talked about this on your slide, but I don't know if you want to just summarize your.
Yeah. So the advice is that not to get vaccinated if you've recently had the coronavirus infection, if you've been diagnosed with coronavirus. That's as much about the supply and just waiting at the end of the line patiently because you have naturally acquired immunity. Interestingly, the French government late last week said that people who'd had COVID did not need to get a second dose of vaccine. There have been reports of anecdotal reports of people who've had the disease, who've gotten a second dose, who have higher adverse events, just like sore arms, feeling bad, not doing, sort of out for a couple of days. So we'll see how that plays out. CDC may issue guidance on that. I haven't heard anything, but the French are equally as competent. So that's what they decided. There are an infinite number of variants. And the question is how well does the immune system recognize them? There's work currently ongoing. There was a great article in the New York Science Times today, which is comes out on Tuesdays, about work for a universal coronavirus vaccine that would work against the cold viruses, against SARS, against the Middle Eastern respiratory syndrome, and against COVID-19, based on parts of the virus that are really conserved between all these different strains and don't seem to mutate. That would be terrific if we can pull that technology off, because otherwise we're going to have to kind of, play catch up, much like we do with influenza.
Thanks so much. So Aditi from the Sunset asks, can you still be a carrier of COVID-19 after you are vaccinated?
Want me to do that one?
Sure.
You're sure? Okay. We don't know. It's the bottom line. There are very, very scant data from the Moderna and Pfizer trials that looked at people. So the way the trials worked, you got screened to make sure you weren't infected with a PCR test, the nose test, right? Then you got the vaccine. A month or 3 weeks later, you got screened again, and then if you were negative, you got the second vaccine. Okay. So the only period of time for which we have data on to look for the virus itself without looking for symptoms is at day 28 in the Moderna trial. So we can say, okay, within weeks between the 3rd and 4th week after the first dose, we know that the vaccine has about 65% efficacy in preventing viral infection without symptoms. Just forget the symptoms, just viral infection itself. And that's without being boosted. That's for a 2-week period. Okay, now I'm now giving you the total knowledge dump on this. And the Astrazeneca trials are actually looking serially out over time for viral carriage, so we'll know it from that one. But for these others, we just know that very narrow time period. And they were really designed to try and prevent clinical disease from people getting sick, having to go to the hospitals, having to go to the ICUs. That's how those trials were designed. That's what they were trying to prevent, not the viral carriage part. But having said all that, smart money says that it will. So if you want to go down to the, take some money to Las Vegas, that's the bet I would make.
And I'll just add that that's one of the reasons after getting vaccinated that you still have to, do all the mitigation measures of masking and distancing. It's not a free pass yet. We still are gathering data on it, but hopefully that data will show that transmission also decreases, especially given the fact that the majority of the population is not vaccinated at this point in time.
Got it. Okay, perfect. Yeah, I know there's so many questions, and I know we are sort of building this plane as we fly it up in midair. So it's we're gonna have to see what happens. So Sarah from the Richmond asked, the public is being told that even a few weeks after your second vaccination, precautions of masking and social distancing still need to be followed. Is there anything that would be safe to do after the second shot that we shouldn't do now? For example, I'm thinking of having a couple of friends over for dinner if we all have had our second vaccine, right? Because I think people are feeling, hey, I got the second vaccine, I'm just gonna go back to life as I knew it before COVID in people's minds. So what can people do after they've been vaccinated, and what would you advise them to not do or to keep doing, frankly?
I have an opinion about this, but I'd like to hear what everybody else has to say.
Okay, we'll hear from the public health officer.
I'll put dibs on the last word here.
Yeah, there you go. Perfect.
So, I would just say, as one of the public health folks, we really actually need everyone to keep doing what you've been doing, even a couple weeks after that second dose. Now, we are making progress in terms of the case rate and transmissibility. And so if as communities we're in a lower tier of spread, then there may be some permissible activities that are not permissible today, with both our counties still in the purple tier. So it is not clear yet that other chances can be taken, just given the transmission that's going on around us and what we don't know.
Yeah, I'll just echo that. And I'll say that, we still have pretty high transmission rates. This last surge was the highest surge that we've, experienced in California. And so we're not quite at a place yet to say that even if you're vaccinated, X, Y, and Z is safe to do. I think we really want to see those transmission rates go down and get a little bit more data.
So on November 21st, 1918, 10 days after the armistice was signed, San Francisco rescinded its mask order. And at noon on that day, all the sirens and whistles blew in the city. People ran out, they threw their masks into the street. The Chronicle said that Market Street was a sea of gauze. And 5 months later, there were 1,800 more deaths. Okay. All right. So you got to be a little careful here, right?
And that was after people had got vaccinated, you're saying? Or this is just...
no, this was from 1918 influenza. There was no vaccines for it. But still, this is real cautionary stuff, I think. And, we could easily have a fourth wave of transmission, easily. Now, having poured all that, water all over everyone, I think that if you have people coming to dinner, both of whom have been vaccinated and they're 2 weeks out, and the hosts have been vaccinated and they're 2 weeks out, you don't need to wear masks. I think, but for me, wading into a crowd, think Costco on Saturday afternoon, okay? Just as a kind of a marker. Even though I'm vaccinated, I'd wear 2 masks.
Mm-hmm.
So I think you have to assume that you're one of the 5% who's failed the vaccine. And you have to assume that everyone around you is infectious, right? And I think if you do that, you're not going to take any chances. But if if you have a small group, people have been vaccinated, I think that's I would say that falls on the safe activity. CDC doesn't say that, but I think that's probably where we're likely going to end up here sooner than later.
Got it. So that's sort of another question that's not vaccine related, but the 2 masks, right? Now, we had guidance for 1 mask. I've been wearing this very simple mask, right? It's just a cloth mask. It sounds like we'd be wearing 2 masks now. And can you sort of walk us through that and tell us why? Or if we should, sorry.
It's basically, CDC has some modeling data. This is the Centers for Disease Control, not the California Department of Corrections, just to be clear on this. CDC has some data on that two masks cut down the potential for spread outwards. You know, I think we should be spending our energy on trying to get people to wear one mask, frankly. But it is now, it's now kind of come into the sort of popular culture. And I'm, so the problem is that you have an N95 or a KN95 and a surgical mask. So which one goes on top of which other?
Mhm.
So this doesn't work very well because it bags out here at the side.
Right.
This works much better.
Mhm.
Try keeping your glasses on. I looked
no
like
problem.
George W. Bush, my ears were pulled out like that. My glasses kept falling out. So it's hard. But I wear double masks when I go out into, like to the market or to, I know I wouldn't go to Costco and say, but I wear double mask when I go, if I were flying across country, I'd wear double mask.
Yeah.
I mean, I think it's a reasonable standard of protection and one that we shouldn't discourage. Now, wearing, one of these things that you look like the Sundance Kid and something else, just wear two surgical masks or wear a KN95 and a surgical mask. I think that's fine. Or wear one of the ones like you have that has a filter in it. That actually works just as well, but you can't walk around with it underneath your nose like the football coach.
But if you're out taking, you're out walking your dog and you're just walking around your neighborhood just to get some exercise, that sounds like it's a different.
I mean, if you're going to wander into a big crowd, right? Do it. If you're not, just wear one.
Yep.
Please wear one. Okay.
Yes.
At least, please, at least wear one.
I think that's our message too, is that we really want people to adhere to the one mask. And if you feel really comfortable and you're not like pulling it down and you're able to take on the second mask or wear an N95, there's definitely options for that. And it is a bit nuanced. It's not, just layering two masks on top of each other or, a gaiter and a mask or something like that. So I would urge people to really read about it and how to get that two mask fit to your face as well.
Perfect. So John from the Ingalls side asks, I'm in the middle of getting the Pfizer vaccine. Since there are multiple versions of COVID floating around now and a different vaccine might work better on those other strains, is there a risk to getting multiple versions of the vaccines? So he's getting one vaccine, but he's already thinking about getting his next vaccine. So I guess I don't know how you want people to think about that.
You won the lottery.
That second dose.
Yeah, exactly.
Yeah. John, you won the lottery. You got the good stuff. Yeah, just finish it.
Yeah. Kind of.
This
like
is the
Pfizer. We don't know yet.
No. I mean, CDC says you can do it if you have to, but that's just made up, right? That if you start with one, you could finish with the other. If there's nothing else around, and there's never going to be anything else around, it's better than nothing. That's what that means. Just finish with the Pfizer vaccine. The Pfizer vaccine, first of all, you get it in 3 weeks, not 4. And it's the more protective against the South African variant.
Perfect. So Maya from Merced, got it. So Maya from Merced Heights asked, I wanted to know about how the vaccines affect the teenage/young adult bracket of people. This is good. I'm a teenager. Since most of those vaccinated have been seniors and older health professionals, does anyone know how younger age groups have been reacting to the vaccine?
Well, only one of the 2 vaccines was tested on young people age 16, 17. That's the Pfizer vaccine. And Dr. Rutherford or Dr. Baba should certainly chime in on what that data revealed. I mean, those passed the bar as being safe and effective to have the eligibility go to age of 16. The only eligible 16 and 17-year-olds right now are those who are healthcare workers in our county. So we don't have a lot of those to have heard anecdotally or otherwise as to how they're doing. Nationally, I have not heard a lot about young people and what their vaccine experience has been. If other states,
the Pfizer trial did include 16 and 17-year-olds. There were very small numbers, but it seemed to work okay. There are currently trials being done both by Pfizer and by Moderna to look at 12 to 18 or 12 to 16-year-olds. Those data should be available by April, apparently. And I think that's one of the considerations when we talked about back to school, which is whether we should be trying to vaccinate these teenagers.
Got it. So Lori from Laurel Heights asked, I am my 88-year-old mother's live-in caregiver. My mother's Kaiser doctor told her not to get the COVID vaccine because my mother is allergic to flu vaccines. Her primary allergic response is pain, redness, and extreme swelling in her arm that previously landed her in the ER. She is not allergic to eggs or to albumin. I could be totally mispronouncing that.
Oh, you got it right.
ALBU.
Yeah, albumin.
Albumin, a common flu vaccine allergen. When will science identify COVID vaccine allergens and replace them with more mild components? This sounds like a medical test question. My God.
So, I mean, right now, I think this would be something that you would need to discuss with her doctor pretty in depth, or get referred to an allergist. Having a adverse reaction to a flu vaccine is not an absolute contraindication to getting the COVID vaccine. And so just not knowing the full history, I don't want to speculate, but just to let people know, the true contraindication is if you've had a severe allergic reaction to COVID vaccine, or something called PEG, which is one of the parts of the COVID vaccine that has been associated with severe allergic reactions. But in terms of having a flu vaccine allergy, that shouldn't be an absolute contraindication yet.
Well, she's saying her Kaiser doctor told her not to get the vaccine, so maybe she has to get a second opinion or talk to a Kaiser allergist or something.
There are ways you can make the reactions less severe, just by using ice and stuff, and using some analgesics and stuff.
So in my chat feed, it's saying that Dr. Baba is an allergist. So
I am, and that's why I don't want to speculate, because sometimes you need to get the full history of what exactly occurred to ensure that, in fact, you're identifying what happened and making sure that. But again, this is pretty rare. Allergic reactions are fairly rare, and they've all been reversible. So our goal is really to get as many people vaccinated as much as possible.
Got it. But specifically for Laura, you're saying, if the primary care is saying don't get vaccinated, who else should Lori's mom be talking to?
Yeah, absolutely. She should talk to an allergist.
Okay, got it. So she should talk to an allergist. Very good. This is the last question. So really, again, before we get to the last question, just thank all three of you for taking time out of your extremely swamped schedules. I think that public health officers, officials, doctors have never been more in demand. I'm sure you're used to getting kind of like the annoying questions from all your friends about different ailments, but I think this year probably has been a whole different level of questioning. So we really appreciate your spending some of your very precious time with us and in this virtual town hall. So the last question is Nick from Pacific Heights. Asked, I just read that it is rare, but some people have developed a very serious, potentially fatal blood disease from the vaccine. I'm a senior in good health, but this worries me. Is it safe for me to get the vaccine?
I'm assuming he's talking about idiopathic thrombocytopenic purpura. Would that be your guess, Navina?
Yeah, I would assume so, but that's pretty good that he's kept up with literature that much.
Keeping up with the literature. There have been a couple of cases reported after vaccination. It's not clear at all. This happens without the vaccine as well. It's not clear at all that it's related to the vaccine. If you had a history of having that before, you might think twice about it, but talk to your doctor. But without a history of it, it wouldn't bother me. I wouldn't stop. I would not get it. I mean, this is, this disease has a quite a high mortality rate among people in the age groups we're talking about. COVID, I mean, not ITP.
Oh, sorry, I misspoke. So, we had a couple more questions, but hold on one second. Let me just look at them for one second. And I think while I'm doing that, I was just hoping, one of the things we're trying to just sort of get the message out is if all three of you could just comment on this, or one of you could, it's fine. But just again, how important it is to get vaccinated. Why is it important to get vaccinated? there obviously are a lot of people out there who don't believe in vaccination, don't like vaccines, are very suspicious of vaccines. So if you were sort of talking to them or talking to their friends, give us the pitch as to why it's important for everyone to get vaccinated.
I think we all definitely agree with that as a closing, really important sentiment, that this is a safe and effective vaccine. And despite the speed at which it was brought to availability, the science was rigorous, and public health professionals across our communities and the country just urge folks to get the vaccine, because it's such an important step in protecting not only yourself, but all of us. For some of you, you might have some questions, and there's really legitimate reasons that populations of color, people whose families have had different experiences with the healthcare system or with government or with medical research would want to talk to people you trust. We honor that, we acknowledge that, and you may not want to hear it from the three of us that are on this panel, but this is such an important step that any of us can take when it is our turn. And it's absolutely essential to the community as a whole, moving forward past this pandemic.
I think that's perfect. I do have a couple other questions that I think are pretty important, so let me just get them in quickly. Fet from the city asks, most residents over 65 do not know how to access and sign up for the vaccine on the internet. How can we support them? So I guess for people who don't, just in general, for people who don't have internet access, how do we get them signed up?
Yeah, absolutely. So we know we're getting to the digitally connected first, but all the major healthcare systems are reaching out, have ways to reach their patients via phone or via neighbors or a trusted caseworker if someone is in that kind of position. For our patients, for the patients of the public health system, we're using a lot of different approaches through their trusted either primary care provider, a conservator, an advocate, to make sure we overcome the digital barriers.
Got it. No, thank you. Dr. Bubba?
Yeah, I'll just add that we're also our community-based partnerships and organizations that often interact with our senior populations and upcoming populations as well are a huge resource as well that we're working with to get the word out.
Got it. So Tiffany from Ingleside asks, some pharmacies and hospitals are discarding of unused but expired vaccines due to no-shows. What are your plans to distribute the vaccines to people and avoid throwing them away?
I would just say that I think it's quite rare that there are wasted doses, and every vaccinating entity has an approach to not thaw or make available doses they cannot use, and enough of a waiting list for those who could be vaccinated, at the end of clinic or end of day. So it's very rare that doses are wasted. And we've been really grateful to our healthcare partners who are vaccinating, pharmacies, doctors' offices, the bigger mass sites, and have wasted very, very few doses across the community.
Got it. So John from South San Francisco asked, why are insurance companies charging an administrative fee for the vaccine when the Affordable Care Act or the CARES Act should be covering this fee? So I don't know which insurance companies he's talking about, but I don't know, and I don't know how that's showing up. I don't know if
I could take this one, or Dr. Baba, if you're welcome to.
Oh, please, yeah, just jump in.
So a vaccinating entity can charge an administrative fee to cover the costs of the personnel and space and other support that's being used to deliver the vaccine. You as a resident, you as a patient will receive the vaccine free of charge. But one of the reasons we pay health insurance premiums, whether that's you or your employer, is to enable services like vaccination to be brought to you at no cost.
Got it. Perfect. Thank you. This is really the last question. It's kind of a comment as well as a question, and it's a very much a broader, so feel free to have all of you kind of been. This is the question I get probably all the time. I'm sure all of you get this all the time. So it's Michael from Merced Heights. My wife and I both work in the restaurant industry here in San Francisco. Our careers have been destroyed by COVID-19 restrictions. We may not be able to afford to keep our house or stay in the city we love so much. How do you justify keeping these restrictions when places like Florida have 0 restrictions and are fine. Death rates are no worse than ours. Why don't we just tell vulnerable populations to be careful and lift all restrictions so the economy can recover and those of us who will not die can return to our normal lives? So I think I know I get this question all the time. I'm sure you all do too. So I know you probably have to repeat yourself, but if you could sort of answer Michael's question, would really appreciate it.
Yeah, I mean, I think it really speaks to, oh, sorry, I'll just say really quickly, I think it really speaks to, the pandemic's effects. And what we've seen is basically not only are, certain sectors of society most impacted, including certain communities by the economic impacts, but also those same communities are impacted by COVID. So they're bearing the brunt. It is a balancing act here. We definitely, don't want to, that is not our goal, is to shut down the economy, but we also cannot overburden and cause a lot of death that is preventable, as well as overrun our hospitals. Because once our hospitals get full and they get into care standards that are not our normal care standards, everybody suffers across the county. So we are doing our best to try to balance both of these things. I do think the vaccine is one of the biggest tools to kind of get us back to a place where we're getting towards normalization. I will also say that deaths in older people is not necessarily that we see in every community. So yes, the preponderance of deaths are in elderly communities, but we definitely see in our Black African American communities and in our Latino populations across the country that deaths are a lot more dispersed throughout the ages and age groups. So I think from a public health perspective, we want to really ensure that we can get people to a place where a vaccine is available so that we can then open up safely without people dying. And that's been the major the major part that we're holding and from public health and our major guiding principle.
Right, because I get this comment all the time. It's basically, well, this is really only really impacting people over 65. Why don't they all just stay home and the rest of us can go back to work and live our lives? And obviously that's not the case. That's not who dies. It's only people over 65. So Dr. Rutherford and Ms. Srinivasan.
Sure, I can say that in 1918, from the 1918 influenza, there were 3,000 deaths in San Francisco at that time when the city had a population of 350,000. There have been 342 so far from this. So that's the difference. That's what all this kind of careful management, that's what the difference has been. I'd say that there are 2 other things to say. One is that Sweden tried exactly what we're talking about. They had astronomical mortality levels, 10 times that of neighboring Scandinavian countries, and abandoned it. So that's one thing. And the other thing is that you can actually look at the transmission rates to people over 65. There are a couple of studies that CDC published where you watch the rates go up in younger people, and then in about a 2-week lag, they went up in older people, like over 65. So it's not that people aren't really compartmentalized, especially in this society, and there's too much intermingling, and so it's there's a judgment, there's a political judgment that's been made that preventing mortality kind of trumps other things, and but that's what this has done. I think dealing with the absolutes of 3,000 deaths in a city that's half the size it is now, less than half the size it is now, versus 342 is an astounding accomplishment. And it's, the 342 are hugely unfortunate and horrible and all those things, but it's not 3,000. And, and then I think you have to look at Sweden's failed experiment as really the real proof positive that you can't do that.
Right, and it's no difference than we pass laws around limits. We've passed laws about having children get vaccinated before they go to school. It's very, very similar, different types of sacrifices. But, and I think I remember reading about Sweden when the pandemic first started, and it felt like, or at least based on this article, Sweden's doing great, and we were all shut down, and they were open like it was normal. But I guess it caught up with them.
Ran out of coffins. Yeah.
Ms. Srinivasan.
I think my fellow panelists covered it well, but I would just say to Michael that you know, none of us have been able to escape the impacts, and it's very real, the economic impacts and the impacts to so many lives from the isolation and the connections that have had to be disrupted. We don't know what we don't know. And we don't know that the states that have made different decisions, you know, 100 years from now, when there's the next Dr. Rutherford looking back. But the balance that was made in California was about this protection of unfettered mortality and the spread in a way that we would not recover from. We couldn't recover in a generation as we're positioned to do. But we have a lot more work to do. So we have a lot more work to keep rebuilding and repairing to a better next normal.
Well, I think the feeling is that if we didn't take these precautions, we know that 47,000 deaths would be a much higher number. So I think there is that. We don't know how much higher, but there's a feeling like if we had done the Sweden model, that number would be significantly higher, let's say. So again, let me just thank our three amazing panelists for taking time out of your your super busy schedules right now. Really appreciate you taking this time to educate the public, talk about these questions that are, you know, really top of mind. We really, really appreciate it. I do want to let everybody watching know that the next town hall I'm hosting is on March 16th. We're going to be talking about schools, and at that point, hopefully we'll be seeing or hearing more about schools reopening, but that'll be our next topic on March 16th. But again, thank you so much to Dr. Baba, Dr. Rutherford, Ms. Srinivasan. Really appreciate your time, and thank you again so much for spending your time with us.